Okay, AC joint rehabilitation. Now, what did, if anything, in literature did you find in terms of rehabilitating some of these AC joints?
It's very deep, super specific, laid out algorithms, aka you ice it and sling it. Then you step
Hold on,
two,
back up. You ice it, then what?
sling it.
Whoa.
Set it in a sling. Step two, like rehab it. Like that's what most of the articles are saying. Like, well, just do some rehab, And then there's like a higher end function after that, more sport related movement, and then return to sport. But in other words, I mean, we were talking about this. It's not an area that there's not like this definitive approach to rehabbing AC separations or sprains. But it just seems like if you just take in my mind, if you just take the approach of what does the AC joint do? What does the clavicle need to do? I know that it rotates a bit and it elevates a bit, it retracts a bit. So, but I did have to look up the numbers of 5 to 8 degrees of upward rotation, 11 to 15 degrees of elevation, and 15 to 29 degrees of retraction in a full abducted arm.
Oh, wow.
Right. So I did look those numbers up, but we know that it has to move like that. It has to rotate a bit, which is why, like when you look at something like the subclavius can prevent the clavicle from doing its upward rotation. So that is a marker that can prevent the full function of that the clavicle from moving. And therefore you may not get fully rehabilitated, for example, in that AC joint. And a lot of times after too long of immobilization, you get issues. So you get in these slings and you maybe did it too long, or even being in a sling. I think they recommend like a week for like grade 1 and like up to 18 days for grade 2. And in my mind, that's crazy. That's pretty long. I guess if you're just in terrible pain, then by all means support it. But the longer you immobilize, the more restricted you get. And there's more reasons why subclavius may be locked up, but immobilization can be a reason why you don't really have that full function. So then you go do whatever quote rehab exercises are recommended, walking your hand up the walls and Codman's shoulder exercises and all that stuff. But let's say you're doing those, but you don't have upward rotation of the clavicle, you don't have retraction and elevation or whatever is restricted, then you don't have proper movement of the scapula. So how much can you possibly get out of your rehab? So that's kind of what I would look for. And I realize it's very difficult to assess 5 to 8 degrees of upward rotation. I mean, I can't feel it on myself hardly, but you can do things like look at the space between the clavicle and the first rib, see how tender that area is, see if they have like a downslope to their clavicle versus an upslope. There should be a slight upslope. So a lot of times after releasing a subclavius, for example, you can see the clavicle kind of upsloping afterwards. It's possible anyway.
I mean, I think that should be part of the kind of general inspection of the AC joint. Like, I know you're probably palpating around the AC joint, but as that clavicle is essentially a part of it, you need to be kind of palpating kind of outwards. And it's very common. You'll find a very sensitive kind of clavicle, and people won't have realized it until you start to palpate it just a little bit. And it's usually sensitive because it's stuck. I actually think that's one of the, if it's non-traumatic, just to switch lanes a little bit from that trauma, why that subacromial disc space, that acromial space, it becomes lessened. If that clavicle is, let's just say it's anchored down, right, by your subclavius, by your pecs, and then your arm is going up, if that clavicle is yanking it down, that subacromial space, that's where a lot of this degeneration is coming from, those movements not matching up, basically, right? Which is why those things are very important. And we kind of talked about, there really needs to be a better name, but kind of the suprahelix angle of the clavicle to the shoulder blade being at or above 60 degrees. And if you see that less than 60 degrees, then there's a good chance there's some sort of impingement or compression on that area that needs to be decompressed, whether it's posteriorly, anteriorly. But yeah, let's get into some of the function. We teased it earlier, the coricoclavicular ligament being attached from the scapula to the scapula.
Coracoacromial. Yeah.
Coracoacromial. Good. I can't say any words today.
No, it's good. Those are all just mouth fulls. It
They're
gets
all
really
mouthful.
tiring. But the coracoacromial, because it's going from itself to itself, and it doesn't tie into a muscle or anything. So it seems kind of a fair question to ask, right? Like, why? What's it there for?
Yeah. When I was researching this episode, I was like, what the heck? What did you come? Yeah.
What I was looking up was talking about it does act as a buffer or restricts the superior translation of the head of the humerus.
Oh.
So it can check superior translation.
Okay.
Especially if you think of all the impingements you see. You know, those humeral heads that look like there's no subacromial space, and they're so far forward they look like they have this like forward ball coming out of the front of their shoulder.
Sure.
But it's not a deltoid, it's their humeral head. That it checks that superior translation.
Yeah, I heard the superior translation, but then also as it's rotating up causes like a pivot at the humeral head so that it starts to swing back. Otherwise, as it was going up, it would stop in my mind, I think of anterior translation. So it kind of just clips it like you would be kind of like clipped in like hockey or something like that. And just helps it spin upwards.
Yeah, it's good. It's like a hinge point where you hit it,
Right.
and then that bone starts to slide down, and that's why we all talk about posterior capsules and inferior capsules, because those also have to be loose enough to move into. Otherwise, right now you have impingement or you have AC compression.
I got to say, man, after that last episode, you talked about a patient, you did a bunch of posterior inferior manipulations, like 70 something on a patient, like a bunch, and got him out of pain. And I was thinking about that with actually two of my patients today. I was like, man, I probably need to put a little bit more force into this posterior inferior capsule. But I loved it. This is when I know that my mind is really working well. I came up with a new little technique. Doesn't really matter what it is, but it just suffice it to say, it's very important to get your shoulder back into the socket. And there's a difference between getting your pulling. I say this to patients all the time. There's a difference between pulling your humerus back into socket than pulling your shoulder blades down and back. Again, see the last episode.
Big difference.
Big difference. What's I mean, we talked about this. So if you want to reference this, don't pull your shoulder blades down and back. We've got options for you. Find a way to get your humerus posterior and inferior for a happy shoulder.
We have these mulligan techniques for the hip too, right? Or you can do them manually with your, the leg over your shoulder and your hands locked right in front of their hip. And I've always done these. I mean, a little bit from, who I learned this from, like, I've learned it in school as, do a thrust. It's almost like a adjustment.
Right.
And then when I started doing, I didn't even count. I just know it's a ton of these. Then it clears out, and it also maybe has a little bit more longevity to it than just a single pull or a couple thrusts. So, I mean, I've always done, like for the hip, tons in the 30s, 40s attempts, just as hard as I possibly can, especially a hip, because you can just pull. With the shoulder, it's a lot more controlled, but definitely high volume to try to get some capsule movement in there.
Yeah, like there's this quote that's constantly kind of going through my head in the gym, like, how much pain are you willing to endure to improve? And when you get to like some of these painful manipulations, it'll get a little sensitive for the patient, but you kind of have to push through to that level. If you understand the manipulation you're doing, you've got a good history on the person, you know what you're doing, the patient's going to fight it a little bit. You know what I mean? Just because their body's not used to it. They may start. I was working on a patient's peroneal muscles today, and she's like, I'm sweating bullets up here. There are some of these things that are just very deeply kind of attached. And if I'm going to do a bunch of rough manual therapy, I'm going to find some garbage tissue where if I work on it, it makes you sweat. I know that it has a neurological impact. Same thing to do with these capsules. They're robust. They can take some tension. They just don't take a lot of that posterior inferior tension. Same thing with the hip capsule you're talking about, or the hip capsule versus the shoulder capsule. I've found those to be incredibly beneficial.
Yeah, I mean, you can think of just where do these we say asymmetries come from in the capsule? Well, a lot of these, Yonda-esque anterior pelvic tilt or sway back postures where the femur is just pushing the anterior capsule forward all the time, and then you say, "Hey, can you show me a squat, please?" And they can squat nowhere near parallel, much less all the way down. Or you put them on the table and you see, a scour test is painful and they can't bring their knee up, right? So they have these lax capsules on one side and tight capsules on the other. And that's just based on a lifestyle and a history of forcing those bones in certain directions, and the body will adapt to that. There's no stress in one direction. Well, it's not going to be there for you.
No,
So,
I mean, whatever you're doing, you're getting better at it.
yeah.
Whatever posture you're in right now, listening to this, watching this on YouTube, you're getting better at it. Yeah. Same thing when you go to train. Whatever positions you are loading up, you're getting better at them, right? Let's get a little bit more to training. So, like, I think, okay, the fooshes, this is a big one if you're falling on an extended arm, foosh, an outstretched arm. But there are some training ones, like, for instance, biceps,
hand.
Falling. What did I say?
I don't know. You said matter. Falling on an extended arm or something. It was great.
Thank you. Fossa. It's Nick Bosa's cousin. But you were talking about bench press.
Yeah.
Why bench press? Bobby's becoming a man over there.
Every now and then I just revert to my adolescence.
That's okay.
Prepubescent time.
Bench press can cause a problem for AC joints.
Mm-hmm.
Why specifically is that? And then I'm going to counter your point.
Well, I mean,